Hi, everyone, and welcome to Massive Bio's event showcasing myelofibrosis. I'm joined today with Dr. Yacoub. My name is Fiona Evans, and I am the Director of Patient Advocacy here at Massive Bio. And Dr. Yacoub, welcome. Please give us a little introduction.
Hello, Fiona, and hello, everybody. I hope everybody's having a great day. My name is Abdulraheem Yacoub. I'm a professor of medicine now this year.
Congratulations.
Thank you very much. This is great, exciting times. I'm a professor of medicine at the University of Kansas in Kansas City. This is an NCI Comprehensive Cancer Center. I specialize in blood cancers, predominantly myeloproliferative neoplasms and myelofibrosis.
Great. Thank you and welcome. We're happy to have you. So my first question for you is, can you give us a brief overview of myelofibrosis, the symptoms, how it's diagnosed, and what type of testing is needed?
Yes, absolutely. So, as the introduction mentioned, myelofibrosis is a blood cancer. It's a relatively aggressive disease in some individuals, but it could carry a range of a spectrum of severity in different patients. Um, it's a disease with a hallmark of proliferation. Basically, the bone marrow is busy producing blood elements. Those blood elements can be white cells, immature cells, as well as excessive scarring in the bone marrow. And patients subsequently will manifest abnormal blood counts. They would have worsening hemoglobin, worsening platelet counts, rising white cell counts, rising immature cells. Patients with myelofibrosis have significant symptoms because of this process going on in their bone marrow. In addition, there's extra manifestations outside of the bone marrow, such as extramedullary hematopoiesis. So patients with myelofibrosis have enlargement in their spleen because of the disease, which results in specific symptoms, including abdominal discomfort, abdominal pain. When the spleen is too big, it can cause pressure in the stomach and an early satiety, and subsequently patients can lose weight and can lose their ability to thrive living with this cancer. Unfortunately, it's a progressive cancer, and patients who have a diagnosis of myelofibrosis will have a shortened life expectancy because of their disease. And our tools and medicines aim at tackling the disease manifestations, the disease symptoms, the enlarged spleen, but also to address the fact that patients do live shorter lives and worse quality lives with myelofibrosis. So that's all incorporated in our goals of treatment for those patients. The diagnosis includes a collection of blood tests, imaging, as well as a bone marrow biopsy. A bone marrow biopsy is absolutely necessary in making this diagnosis. There's a lot of diseases that look like myelofibrosis, and there's a lot of diseases that cause fibrosis of the bone marrow that are not myelofibrosis. So it's a collection of symptoms, physical findings, blood findings, and bone marrow examination in order to define this diagnosis.
Got it. Okay. So what are the current treatment options for myelofibrosis?
Well, at this current time and age, the only cure is allogeneic stem cell transplantation. That is basically a transplant of a bone marrow from a different donor to the patient after a bridging therapy of a chemotherapy that would wipe out the original bone marrow. This is the only cure, but it is a process that includes aggressive treatments and some complications and morbidity in association with that. Many myelofibrosis patients are actually eligible for this. So this is an important question to be asked early on after the diagnosis has been made or after a progression event of the disease. So it's always it's a question that needs to be asked for every individual patient, whether cure is an option. For all patients who don't have a transplant as an option, and also for patients who are going for a transplant, treatment with JAK inhibitors are the standard treatment for all these patients. There are multiple JAK inhibitors that are approved, with ruxolitinib being the first in
Mhm.
drug approved for this disease, the drug with the most history and the most um, proven benefit, including survival advantage. Um, and also two other JAK inhibitors have been approved since then, fedratinib and pacritinib. So all these three drugs are approved agents for myelofibrosis. JAK inhibitors provide a great value to patients. They are very good at symptom control, so they relieve a lot of the symptoms related to myelofibrosis, the night sweats, the weight loss,
Mm.
itching, the fatigue, the failure to thrive. So they're very good at improving the symptoms. They're also very good at shrinking the spleen, which is of specific value to patients in terms of improving symptoms because of the spleen, and also improving their well-being and improving their candidacy for a bone marrow transplantation. And ruxolitinib specifically has been shown to improve overall survival. So patients who received ruxolitinib actually lived longer because they received ruxolitinib, with a proven evidence in multiple clinical trials. So, for all these purposes, patients with myelofibrosis should receive a JAK inhibitor, maybe even multiple, serially of JAK inhibitors, as well as being evaluated for a bone marrow transplantation for cure.
Great, great. So it sounds like either, bone marrow transplant or a JAK inhibitor, are quite successful treatment options for
Correct.
patients.
And we do
Great.
have a few other therapeutic options we call supportive care. So
Hmm.
for patients with myelofibrosis who have unique symptoms, bone pain, anemia, so we do also provide other supportive measures such as growth factors, transfusion support,
Hmm.
symptom management, to try to supplement patients whose needs are not met by the available options too.
Right. Okay. That's great. So are there different, more promising treatments out there with clinical trials for myelofibrosis?
Absolutely, and always. Yes, we are. Again, this is the most exciting aspect of discussing this disease, is
Mhm.
how promising the future of this disease is sounding. There are many agents in late phase clinical trials, meaning these are agents being investigated in clinical trials, and they are ready for FDA approval if the study is positive. So
Mhm.
there are multiple agents in that setting. At the forefront of the diagnosis, early on, first line therapy, there's agents being studied as a second line or as a combination for ruxolitinib, for patient myelofibrosis with ruxolitinib. And there are multiple agents that are not JAK inhibitors that also being investigated after JAK inhibitors fail. So there's really progress on all these aspects at the beginning, as a combo, and at the tail end after everything else fails. Some of the more immediate agents that are about to become an option for our patients are a fourth JAK inhibitor called momelotinib. So this agent has been through rigorous clinical trials in multiple settings, and it's the most recent clinical trial that was positive and announced recently, showed exciting responses in patients, and hopefully this becomes another JAK inhibitor that we can offer to our patients. And obviously, all these agents are unique. They're not only JAK inhibitors. Each one of them has different attributes that makes it more important in unique patients. So hopefully soon we're going to have a fourth JAK inhibitor. There are multiple other agents that are in those late clinical trials and will soon have multiple options that we can discuss with patients. And maybe in the near future, we'll have combinations for patients upfront that we can offer those patients. And then at the same token, we are designing agents that are specific to certain patient vignettes or certain patient mutations and certain disease subsets, especially patients with progressive disease, for which we can provide additional options for our patients.
Yeah, that's great. That's wonderful. It sounds like, there are so many different options available. And I think one of the important things to point out is, clinical trials are available at every stage of disease. So, patients shouldn't wait until they've exhausted all options. It's possible they could enroll into a trial when they're diagnosed.
Absolutely. And there
Yeah.
are so many different clinical trials that are running, and nearly every patient can contribute to the process. And
Hmm.
it's our duty as physicians to give advices to our patients, and some of those advices is to counsel them about how they can help move the field forward. So an example is tissue banks and the patient registries out there for patients can go in. They can donate some of their blood samples for research. They
Hmm.
can donate their time by filling questionnaires and surveys that provide a global understanding of disease burdens and symptom burdens. So a lot of those studies are available for all patients all the time, non-interventional studies. Interventional studies include studies that are very robust in the first line setting. So, a lot of our patients now are being offered first line therapy on a clinical trial where you get a ruxolitinib or ruxolitinib combination. And there's
Hmm.
been a lot of those studies that are very mature, and soon we're going to have results to discuss with our patients. There are also studies designed for patients who are not doing so well on successful on first line therapy, who can be improved upon, and then agents for patients with more advanced diseases in which therapy there are no approved agents of benefit, and patients can undergo rationally designed studies with agents that are promising in that field.
Great. Great. So it sounds like, um, clinical trials have improved the treatment of myelofibrosis over the last number of years.
Absolutely, yes. It's an exciting momentum to join, an exciting time for us physicians who treat these diseases, and for patients who are diagnosed and have all this wealth of knowledge and all these exciting options to choose from.
Right. Yep. That's great. So, um, you know, how do so if I was a patient who was interested in a clinical trial, how would I approach that with my doctor, and what, benefits or risks would be involved in that?
So again, I think it's a duty for both on the treating physician and on the patients to ask that question at multiple times during their
Hmm.
journey with cancer. So there are many ways to tackle this. It's always important that patients be proactive about their interest in clinical trials. There's really a lot to gain for the patient by being part of this experiment. One way is to specifically go and ask their treating physician if they have trials or they know of trials in the region that they could approach. There's also federally provided websites where patients can go in and search clinical trials according to their diseases, and that is available to everybody. And there's now a lot of platforms um, that provide that service, and I'm sure Massive Bio can also be one of those resources in which patients can call their peer, can call a third party, talk to a peer or to a healthcare provider or to a research specialist, and get help in that aspect. Of course, joining a clinical trial could be intimidating. There's always this concern on trying things that are new or untested or of unknown value or unknown risk.
Hmm.
So, and that's always intimidating, and we take this very seriously as investigators. But clinical trials are designed with a high bar of safety, and although we all want results and efficacy, but we don't jeopardize safety. So a lot of those trials are designed with significant scrutiny and emphasis on safety being first and efficacy being second. So, and it's always an informed decision. Patients have to hear the whole discussion,
Mhm.
here's the pros and cons, consider their alternative options, and make an informed decision based on all this information. Which, at the end of that process, whether patients go into the trial or not, they become a more informed individual. So, again, having that discussion itself is enriching to the patient and more
Right.
empowering for them to make better decisions.
Right. Yep. Absolutely. And I always, tell patients who we help with clinical trials that patients who enroll in clinical trials tend to get a little bit more extra, I call it TLC. They're watched a
Yes,
little more closely so that,
absolutely.
it's because of those safety issues. They're the site and the physicians are making sure that safety is first. So that's really
Mhm.
great for, all patients to consider. Um, so, in terms of myelofibrosis, what is the role of precision medicine in treating this disease?
Thank you so much for this question because
Mhm.
honestly, myelofibrosis is the model disease in which individualized therapy has evolved, and it really set some records there. So, until 2004, we really had no knowledge of those driver mutations and the unique subsets of myelofibrosis. So, all myelofibrosis was myelofibrosis. We really didn't even know why these diseases occurred. In 2004, JAK2 was discovered. That was a big revelation because that was always the driver that we were looking for that explains why patients get cancer, why patients get this cancer specifically. And between 2004 until 2011 was the first FDA approved JAK inhibitor. That is a record time between finding a target and having an FDA approved drug to target that to attack that target. That's probably the fastest in the history of cancer care that a target was identified and the treatment was approved for that target, which is exciting. Again, and then we learned a lot since we had a JAK inhibitor. We knew that although JAK two is identified in about more than half the patients, but all patients respond to JAK inhibitors. So really hitting the pathway rather than hitting the mutation became the theme. And then since then we've identified additional targets. So we have more access to genomic testing, molecular testing, dynamic testing, in which we can identify patients who are at different risk. And since then, we've developed prognostic scores in which now we address patients according to the risk. So patients with higher risk get more care, more attention, more aggressive therapy. Patients with lower risk get more conservative
Mhm.
approach. So now we classify patients according to their disease characteristics and treat them accordingly. We transplant them at a different timeline based on the risk. We offer them different clinical trials based on the risk. So we're really doing a lot of individualized care based on unique disease characteristics. And then the next wave will be we actually treat patients differently according to their molecular signature. So that's the next wave of advancements for our patients.
Great. Yeah, so it is really beneficial for patients to have molecular testing or biomarker testing to see if they have any of those biomarkers so that they could potentially receive you know individual treatment or personalized treatment to help them.
Absolutely. So again, this is the next quantitative leap in the world of myelofibrosis is that we have a mutation specific treatment. So So the most immediate impact is now a unique mutation called chirotectin, which behaves in a specific way in myelofibrosis. It causes a protein to be mutated, and this protein is expressed on the surface of the cells. It's attached to the receptors on the surface of the cells, which created a new target. This protein is only present in patients with that mutation. It does not exist in any other condition, whether it's normal or cancerous. So those patients with that unique target now have a new drug, and that
Yeah.
drug is now in clinical trials. So now we're designing clinical trials specifically to patients based on their specific mutation. So that is very exciting. So hopefully in the future, we're not going to treat all MF patients the same. We're
Right.
going to say what kind of MF you have, then you get this particular therapy. Another example is IDH mutation. So we've also designed specific clinical trials for patients with that mutation, in which we combine um, um, agents that target that mutation along with JAK inhibitors. So this combination that hits the JAK-STAT pathway and the IDH pathway, and this combination has been investigated in clinical trials. There's more than one trying to address that unique combination of mutations altogether. And there are many others that are in the pipeline that are, again, mutation-specific testing. So we know a lot more now, and
That's great.
we're designing studies to match those unique vignettes and those unique drivers in different patients. So this is the exciting next wave of advancements in patient myelofibrosis.
Yeah, that's great. It's very exciting. We're going to take a little, we're going to stop questions here. We have a little video to watch regarding myelofibrosis, its progression over the years. So we'll get that video started, and then we'll come back for the rest of our questions.
Wonderful.
Blood gives life to the human body by carrying oxygen and nutrients to organs and tissues. However, production of healthy blood cells can be disturbed by myelofibrosis, which is a cancer that forms in the bone marrow and can affect the body in many ways. The first recorded case of myelofibrosis dates back to 1879. In 1951, it was first classified as a myeloproliferative disorder, which is the name for slow-growing cancers that affect blood production in bone marrow. Doctors had different names for this disease over the years, but settled on primary myelofibrosis in 2008. So what causes myelofibrosis? The short answer is that no one is quite sure. But we know that it begins in bone marrow, which is soft tissue inside most bones that makes blood cells. Blood cells are formed from immature cells called stem cells. Sometimes a stem cell can develop a change or mutation in its DNA, which makes it behave abnormally. That mutation can be passed along to other stem cells. As these abnormal cells grow, they can cause inflammation, which produces scar tissue in the bone marrow that interferes with normal production of blood cells. About 1 in 5 patients with primary myelofibrosis eventually develops another blood cancer, called acute myelogenous leukemia, which is the most common form of acute leukemia in adults. Sometimes myelofibrosis can be caused by other related blood cancers called myeloproliferative neoplasms, or MPNs. In that case, it's called secondary myelofibrosis. Myelofibrosis is a rare disease. It's estimated that there are 1.5 cases for every 100,000 people in the United States. That means that in a city with a population of 200,000 people, just 1 or 2 might have myelofibrosis. Anyone can develop myelofibrosis, but it's more common in certain groups. That includes males, men and women over 50, and people of Ashkenazi Jewish ancestry. Being born with certain gene mutations makes you more likely to develop myelofibrosis. You may also be at risk for this blood cancer if you have been exposed to high levels of radioactive material or industrial chemicals. Some people with myelofibrosis have no symptoms, but others develop specific physical changes. If you have this blood cancer, your levels of red blood cells may decrease and cause a condition called anemia, which leaves you feeling tired, short of breath, and lacking strength. Your skin may also become pale. Myelofibrosis can also cause your spleen to grow larger. The spleen is a small organ inside the left rib cage that filters blood and makes white blood cells. As it enlarges, you may have discomfort in the upper abdomen and feel full even though you haven't eaten. You may also bruise or bleed easily and get a lot of infections. Other symptoms of myelofibrosis can include undesired weight loss, night sweats, itchy skin, fever, and bone or joint pain. If you have myelofibrosis but no symptoms, you may not need treatment right away. Instead, your doctor will monitor you with regular checkups and lab tests, which is called watchful waiting. If you have myelofibrosis symptoms, you may be a candidate for a stem cell transplant, which in some cases cures this disease. In this procedure, healthy stem cells are infused into the patient's bone marrow. The goal is to restore normal production of blood cells, but not all patients are eligible for stem cell transplants. If you are not a candidate for a stem cell transplant, your doctor can recommend several treatments to bring symptoms under control. Many myelofibrosis patients today take medicines called JAK inhibitors, which ease symptoms of spleen enlargement by blocking a protein that promotes growth of scar tissue in bone marrow. Other patients may receive a type of drug known as hydroxyurea. If medicine can't control severe symptoms of an enlarged spleen, your doctor may recommend surgery to remove the organ, called a splenectomy. Myelofibrosis patients have another treatment option. Enrolling in a clinical trial can give you access to new therapies months and even years before they're available to other patients. These advanced treatments can be life-changing, and some may even offer a cure. There are currently over 100 clinical trials of myelofibrosis treatments underway or getting started around the world. Give yourself the gift of hope by learning about all of your myelofibrosis treatment options.
Thank
Hi,
you very
Amanda.
much for that, Fiona. That was a very, very informative and very comprehensive video. I think a lot of patients would find it very helpful to review even multiple times. Now, how can Massive Bio help myelofibrosis patients and cancer patients in general to access more up-to-date information and clinical trials?
So first, yes, thank you for that. That was a really great video. But Massive Bio is committed to helping patients connect with and enroll into clinical trials. So what we do is offer a service that uses our AI technology, or artificial intelligence technology, to sort through all of the available clinical trials that are listed on, clinicaltrials.gov. I know you mentioned that there's this site available to all patients and physicians. It is a huge website that houses all the information regarding clinical trials. So what Massive Bio does is we take that information, we sort through options for patients, and we provide them a personalized report of clinical trials that they are eligible for based on their disease, their medical and treatment history. And we also try to identify trials close to home for patients. So we understand that, traveling may not be an option for them. So we look based on where they live to see if we can identify something close to home for them. We can assist that patient in the enrollment process. So once we identify trials, our oncology team reviews those trials with the patients and the patient's physician, and then we can help that patient enroll into the trial. So scheduling their first appointment at the trial site, assisting with any operational issues that may pop up. We really want to make sure that we're assisting the patient not only to identify the trials, but also to enroll into the trials, which can be challenging and, can take some time. So we want to provide that assistance, quickly and as smoothly as possible for the patients and, for physicians. We can help physicians identify trials for their patients. We know how busy and hardworking physicians are. So we're happy to help locate those trials and enroll patients should they, find a match.
Well, thank you very much for introducing your services and for actually providing that much needed service to patients. In cancer care and clinical trials are hard to navigate,
Absolutely.
even for the most informed individuals. So it's always good to have an advocate and a secret helper behind the scenes to connect the dots and connect people with with what they need. Thank you for doing that.
Absolutely. We're, at the end here, we'll show you our contact information. We can be emailed, called. We have QR codes. We're available online. So lots of ways to get in touch with us, which we'll share at the end here. But on that line, as a physician, what do you recommend patients do in terms of looking for reliable information about myelofibrosis?
Thank you. Thank you again. This is becoming a more complicated aspect of learning at all aspects in healthcare and elsewhere. There's a lot of resources online, and there are some are more valuable than others. I highly value the patient-physician relationship, and I think a lot of what we do in our clinic, a lot of the time we spend with the patient is purely education. Honestly, I think that's the biggest help we provide to our patients, just to teach them more about themselves, about their diseases, about their options. And I think it's hard to filter and navigate all these resources out there. There are really good resources that one can refer to, like patients up to date, the patient portal and the NCCN websites. So the NCCN has a great resource for patients and guidelines and so forth. And there are a lot of support groups on social media that provide some value. But I really want to emphasize that a lot of this knowledge needs to be taken back to the office and being discussed again between the patient and the treating physician to make sure they provide the context and the narrative in which this actually applies to them or doesn't, right?
Right.
So, and kind of debunk some of those misleading information or outdated information. So even knowledge changes. So some things could have been a fact at one point, but the science has moved on, and the websites have not updated their content. So it is very important that patients leave an open discussion channel with their physicians to try to kind of filter some of this misinformation or incomplete information or outdated information and get the more current applicable data to what pertains to their own health. And there's always the option of seeking online and second opinions or other options if your physician feels that this question is very unique or specific, that this could be delegated to a different specialist. Like if my patients come in asking specific bone marrow transplant questions, when I'm not a bone marrow transplanter, I will definitely refer them to my colleague who knows a lot more about this than me, and then the three of us eventually circle back to each other and make sure we all heard the same words and the same consultations. And patients with myelofibrosis will live with their disease for the rest of their lives unless they get a bone marrow transplantation. So even their disease will change. And
Right.
some of the information that they learned at one phase of their disease will change when they move on to survive their disease and live with a different phase of their cancer. So they might need to learn new information that is more pertinent to their new state. And that's why this is an ongoing process. It doesn't ever end. Nobody's ever caught up with knowledge because knowledge changes and diseases change, and we just need to keep this process dynamic and live and multifaceted.
Great. Yep. Is there anything that patients with myelofibrosis can do in terms of lifestyle changes to improve, their well-being and their overall health?
Absolutely. And this applies to patients with myelofibrosis and patients who don't have myelofibrosis or patients who don't have cancer altogether. Healthy life
Mhm.
choices are very important to all of us. Dietary changes in which patients make a more healthy aspect of their choices, calorie intake, food, using antioxidant diet or Mediterranean diet, or all that is absolutely important, whether you have cancer or not. But again, it becomes even
Mhm.
more pertinent when cancer is another struggle that you're dealing with. Activity level. Patients who are more active have better performance functional status, who can um, actually qualify for more treatment options and can tolerate side effects from therapy much better than patients who are not active. So we always breach about the right diet, and then you can always seek a dietitian advice as well as the increased activity level, which is you can always seek therapy and other ancillary services to try to enhance performance status. We also advise patients to talk to counselors or psychologists to try to improve their emotional health and well being, which allows them to cope better with their disease and handle the stress of the cancer and the stress of the treatment and the whole process better. So we always consult with our colleagues from psychology and therapy to try to advocate for better um, um, behavior, better coping mechanisms for the diseases. There are a lot of advancements actually on non-pharmacological therapy, meaning treatment with yoga, treatment with meditation, treatment with diet. There's a lot of those treatment with anti-inflammatory agents. So there's a lot of progress going on in that aspect, and that definitely is something patients should be more familiar with and seek resources for. At the same
Excellent.
token, there are certain behaviors that are disadvantageous, like tobacco use, something we discussed in the video. There are certain
Mhm.
behaviors that could be disadvantageous to patients, and maybe making active choices to avoid these habits can also be of help to those patients.
Yeah. Yeah, absolutely. Um, so how do you think that, or how can patients advocate for themselves to ensure they're receiving the best possible care?
All right, and that is always an ongoing process. So, um, one dimension to this is having a good relationship with your oncologist, good rapport, um, be informed, and seek the best cancer care you can. Um, a lot of the other in healthcare does not end at that, because each one of us has multiple dimensions to our health. So cancer is just one of the battles our patients fight, but there's other medical comorbidities that are very important in MPNs, because patients with MPNs are at increased risk of clotting and increased risk of bleeding and increased risk of cardiovascular outcomes. So tackling cardiovascular health is very important in managing the hypertension, managing cholesterol, um, seeking cardiology care when appropriate. That is very important to patients who live with MPNs and myelofibrosis. And also, patients with MPNs and myelofibrosis are at risk of other cancers. So, being current with your cancer screening, being current with all the age appropriate preventative measures, that is absolutely something we cherish in patients who live with chronic cancers and MPNs and myelofibrosis, which again, and what I just described right now takes a team. So it's not going to be patient and oncologist alone. There's going to be your primary care physician is part of that um, wellness team, your psychologist, you could be a cardiologist. So it does really take a team to take care of each patient, and each patient should build their team, build their village, basically, having the right medical care, the right social support, maybe economic support if that's a struggle through financial advisors. So, really having to have a well rounded care, both medical and non medical, for each individual patient.
Got it. Yep. It's not just, one thing that you have to look out for and treat and manage. It's, the whole picture. So that's very important. We'll jump back to clinical trials now. What are some of the misconceptions about myelofibrosis and clinical trials that you have come across, and how can we address those?
Yeah, so one important fact is that not every single clinical trial is a treatment clinical trial. There's a lot of trials that basically provide general awareness for the disease burden for that patients have to come across with. And those trials can even be ran globally. It's not even through your doctor, and it's something that patients can go in and sign up for, like some of the more famous um, 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 participants in this is the Myeloproliferative Neoplasm Research Foundation, um, in which patients can go in and sign a consent with them and provide records and fill surveys. And the goal of those projects is to create a global or large database that guides future clinical trials and provides um, doctors with the questions that are troubling the patients. What is exactly is going on? What is exactly our patients are up against? And instead of looking at the 20 or 50 myelofibrosis patients in your practice, you look at 100,000 patients and what they're all complaining about. So this is the big advantage of those non-interventional trials. And the other arm of that is the biospecimen bank trials in which patients donate their blood for research, which feeds bench research, which leads to testing drugs in test tubes and come up with new ideas and new drugs that we can take back to the patients to treat patients. So these are some of the low yield or the high yield, low effort, um, low hanging fruit for patients that they can help science with.
Mm-hmm.
Now, the fact that clinical trials are experiments and there's definitely unknown parts of the trial. So everybody who goes in on a study, um, there's always a control arm on those randomized studies, and some would perceive a control arm as an inferior or suboptimum. Now, if we knew that, we wouldn't be running a trial if we already knew the results. So it's wholeheartedly that when a study has a placebo on one arm and a treatment on the other, um, it is carefully designed after federal FDA involvement that this is actually the right way of conducting this study. Um, and all studies, even in the control arm, they provide the absolute standard of care. So, for example, patients who are enrolled in first-line clinical trials in myelofibrosis, the control arm is always ruxolitinib or a JAK inhibitor. So patients are still getting the best treatment out there.
Mm-hmm.
And the study arm would include the same treatment with something else
Right.
or with another intervention. So there's really nobody's getting only a
No.
sugar pill.
Right.
Everybody's getting the best treatment,
Mm-hmm.
and half the patients are getting an extra treatment. And the result could be that, yeah, that actually is successful and two is better than one. or the opposite. Maybe two is not better than one, or maybe one is better than two. So we really do not, if we knew the answer, there would not be a research question going on. So I wanted to reassure patients that even studies that have a placebo or a control arm, there really nobody is a loser. Nobody loses. Both
Mhm.
arms will give you information, and eventually the winner arm will inform the future patient care for the rest of patients who have the same disease. So I hope this is clear to everybody, because the only way to move the field forward and to come up with new therapies is to
A clinical
complete
trial
a clinical
through
trial.
line.
Yes. Yeah, that's the only way to advance the knowledge and get more options to patients.
Right, right. So that's great to know. Okay, and then so my next question, and I think you touched on this briefly, was, should patients consider a second opinion when they're diagnosed or during, their treatment, or do you recommend that, or is it a case by case?
So, as the case for all other cancers, myelofibrosis knowledge has increased substantially in the last few years, and there's multiple treatment options, and all have unique attributes. And a lot of physicians can be able to keep up with a lot of the more common cancers, but myelofibrosis is a rare cancer.
Mhm.
And because of the dynamics of this, a lot of patients have a team of oncologists now. So there's patients who see their treating physician regularly, and every now and then they check in with their second opinion doctor. So when is a good idea to get a second opinion? I think a diagnosis is always important, because A, to confirm the diagnosis, B, to make sure you got all your predictive models and all your genomics tested, and you got a really good baseline on your cancer, you got good counseling about it, you got introduction to all the resources you have. And then patients can live with the disease for a long time, and it's an absolute fact that cancers will change and will get worse with time. We call that progression. Myelofibrosis is a progressive cancer, meaning it gets worse the longer you live with it. So every now and then, when that happens, patients might want to check in with their second opinion and see what's new. What has changed in the treatment? What are the newer options? How else can you tackle this disease? So it's really a never-ending process, and it is a very common and acceptable format now, is that many patients with rare cancers have their treating physician and a national expert at an MPN Center of Excellence, um, that can direct their care every so many years or so many months or so forth, to kind of add a twist or add an option to them and reevaluate their disease every now and then. So that's becoming a very common practice, and a lot of physicians and patients are comfortable with.
Great. Yeah, that sounds, like the right plan. The more eyes and hands you have on you, the better. Um, so I think I have one more question. What does the future of myelofibrosis treatment look like in the next 5 to 10 years?
All right, so I think we've only had approved therapies for myelofibrosis less than 15 years ago. So again, it's really the growth in the last 15 years has been absolutely revolutionary for myelofibrosis. Um, and then and we have much better outcomes. Patients are living longer. We have better understanding of the biology, and then with all of that, we've actually identified a lot about the disease biology that we did not understand before. So some of the big themes now are combinations. Now, if one drug produces certain benefit, and maybe a combination in the right subset of patients can actually result in a faster benefit, or a bigger benefit, or a benefit that lasts a lot longer. So that is being challenged pretty actively with multiple phase 3 studies now. And we will find out the results of these studies in the next 5 years, even not 10 years. So in the next 5 years, we'll hear a lot about um, these studies. Another aspect is the individualized therapy. So now that we have a lot more insight into individual cancer driver mutations and biological pathways driving individual patients, why some patients do better than others. We are designing therapy that is geared to patients with certain disease attributes, whether it's genomic, whether it's mutations, whether it's certain biology that is different, or higher blasts, or other features, or really big spleens, or patients with clotting. So we're designing different studies for different patients, and hopefully in the next 5 to 10 years, we will have different treatment paths based on what is your genomics. So if a patient comes in with this mutation, then you go on this track. If you come in with different mutation, you go on a different track, and so forth. So we're getting much better at that, or at least we're moving towards that. And then we are also trying to identify targets other than the JAK-STAT pathway. So there are many agents who are active, possibly in certain patient population, that are not dependent on JAK-STAT pathway. So we're also advancing the science over there. And hopefully now patients, and we only had one therapy, ruxolitinib, for a decade. And after progression, there was really nothing. Now, many patients get 2 or 3 JAK inhibitors in their lifetime and a few other investigational agents, and they do better. Patients who would like to are open-minded to receiving interventional options and travel to sites that have those options, they get additional gains that can be cumulative and beneficial to them. So I think in the future we're going to have a pipeline of therapies, a sequence of single agents and combinations and different and drugs that work differently, and hopefully we'll be having individualized therapy for those patients. The transplant is also getting better, and the donor pool for transplant is expanding. And now, because patients can receive a transplant from their children, or their siblings, or their parents, so they're really the donor pool has increased because of the new advances in bone marrow transplant. So more patients can receive a transplant, and hopefully more patients are in that pool where a cure can be offered to them.
That's great. That's great. Well, thank you so much, Dr. Yacoub. It was a pleasure speaking with you, as always. We're going to end here, and I appreciate your information and your time, and we will share another little myelofibrosis video and our contact information for anyone that is interested in reaching out to Massive Bio. So thank you, and take care.
Thank you very much. Thank you.